This is the Pick Your Poison podcast. I'm your host, Dr. JP, and I'm here to share my passion for poisons in this interactive show. Will our patients survive this podcast? It's up to you and the choices you make. Today's topic has been highly requested, so I'm very excited to talk about it. This episode is called Murder and Medicine. Want to know what poison is still used as medicine? Why it's called the king of poisons and what it has to do with the very first antibiotic? Then listen to find out. Today's episode starts in the emergency department. Your next patient is a 60-year-old man with a chief complaint of diarrhea. He's pale and ill-appearing. His wife is pressing a cool compress to his forehead. The patient reports light-colored, watery, and liquid stools. He's vomiting and has severe crampy abdominal pain. He denies blood in the stools and hasn't had fever. You ask if anyone else in the family is sick, thinking of food poisoning. He says no. He hasn't been camping or drinking out of mountain streams, making a parasitic infection less likely. Also, he denies recent travel or antibiotic use. On past medical history, he notes high cholesterol, for which he takes atorvastatin, brand name Lipitor. He denies other medicines, over-the-counter drugs, or supplements, and also denies tobacco, alcohol, and drug use. His vital signs are as follows: temperature 98.5 Fahrenheit, or 36.9 Celsius, heart rate 105 beats per minute, respiratory rate of 18, and oxygen saturation 100% on room air. Diarrhea isn't the most exciting chief complaint, though it is a very common one. In the US, it's rarely an emergency. You order labs to check his hydration status and his electrolytes. His elevated heart rate suggests mild dehydration and he's vomiting, so you also order IV fluids. In patients with diarrhea and abdominal pain, a CT of the abdomen can be useful to check for diverticulitis and infection in the colon, so you order that as well. We rarely order stool studies for bacterial or parasitic infections in the ER as they're low yield outside of specific scenarios. In addition, they take days to come back, so we won't get the results. C. diff test, we might order. Infections used to be solely hospital-acquired, but can now occur in the community. If he gives a stool specimen while in the ED, it won't hurt to check. As I mentioned in the last episode, when we hear hoofbeats, we're supposed to be thinking of horses, not zebras, common things being common. Diarrhea in the ER is most commonly viral, like a stomach virus, or a mild case of food poisoning. His labs come back without signs of infection, but showing significant dehydration. His creatinine, a measure of his kidney function, is elevated at 3.2 milligrams per deciliter, or 283 millimoles per liter. Patients always think they're dehydrated after a day or two of diarrhea, but in healthy patients, it really takes a lot longer than that. So it's surprising this occurred with only 2 days of symptoms. It's not impossible. His CT scan is negative, and on your way into the room to discuss his results, the nurse is collecting the stool specimen. You see watery, liquid stool with a whitish color. Most often, the ER treatment of diarrhea is IV hydration, then discharge with expectant management and continued oral rehydration. In this case, however, you tell him he requires hospital admission given the acute kidney injury for ongoing IV fluids. Side note, it's extremely fortunate we found a reason to keep him in the hospital. Back to this in a few minutes. Your hospitalist colleagues take over his care, anticipating another day or so of fluids. The patient's C. diff tests are negative, so are the other stool studies that they order for bacterial and parasitic infections. The patient isn't improving. He continues to complain of abdominal pain, vomiting, and diarrhea. Also, his creatinine doesn't go back down to normal. The hospitalists start looking for zebras. The patient becomes more tachycardic and develops a low blood pressure, neither of which is responding to fluid. If this is dehydration, even from really severe diarrhea, both should improve with the IV fluids. So should his kidney function. And not only is he not improving, he's actually getting worse. They add antibiotics just in case, though they haven't found an infection. The hospitalists consult you in your capacity as a toxicologist. They've already consulted gastroenterology and infectious disease without any luck. You start the consult and begin by reviewing the patient's chart in further detail, noting 3 visits to the emergency department in the preceding 2 months, all for abdominal pain and diarrhea. Scrolling through the chart, you think this might be the first consult you've ever gotten for persistent diarrhea. Certainly, diarrhea is expected with opioid withdrawal. Let's say the patient had an opioid dependency he didn't tell us about. Wouldn't be the first time this happened. But he's now been in the hospital for 3 days. Opioid withdrawal would be improving on its own, even without any intervention. Tons of drugs have the side effect of diarrhea, as anyone who's ever taken an antibiotic can tell you. Chemotherapeutics cause it, but he doesn't have cancer. Laxative, obviously, but he's not getting those. Many plants cause gastrointestinal distress, like aloe and mushrooms, but again, symptoms don't really last for very long. Plenty of toxins cause diarrhea, but typically the diarrhea is a minor concern compared to the other aspects of poisoning. Radiation, for example, causes diarrhea, but more concerning low blood counts, and our patients remain normal. Lithium can cause it. A lithium level is easy to send, but he'd have other signs of toxicity like a tremor. Colchicine is notorious for diarrhea, and if you've listened to prior episodes, you know it used to be dosed to vomiting and diarrhea. But if this were real colchicine toxicity, he'd have had a cardiac arrest by now. Same with thallium. Yes to diarrhea, but no excruciating neuropathic pain. Nothing in his chart for this visit really raises any red flags. But 4 visits to the ED in 2 months isn't normal, unless this is cannabis hyperemesis, every ER doctor's least favorite diagnosis. But he denied marijuana use and his urine drug screen was negative. There is one toxin strongly associated with gastrointestinal distress and diarrhea and frequently presents with recurrent ED visits. It also has stools of this particular description. So question number 1, what toxin is it? A, cyanide, B, organophosphate toxicity, C, arsenic, or D, botulism? The answer? C, arsenic. I do like organophosphate toxicity and cholinergic poisoning for diarrhea, but the patient doesn't have any of the other symptoms like the killer bees, bronchorrhea, bradycardia, and bronchospasm, i.e. a slow heart rate with wheezing and fluid in the lungs. Botulism causes diarrhea, but also paralysis and cyanide, acidosis, and cardiac arrest, leaving us with arsenic, a classic cause of abdominal pain and diarrhea. You treated our patient in the emergency department. Why didn't you catch this? Good question. This case, though fictional, is a real-life scenario, so let me explain. Arsenic as a podcast topic has been highly requested, most recently by an emergency medicine colleague of mine. Years ago, my colleague was in close proximity to a person murdered by arsenic. Telling me about the case, he noted the victim presented to the ER and was discharged a few days before his death. My colleague asked me the following question. When a patient has diarrhea and abdominal pain, complaints every ER doctor treats multiple times per day and thousands of times per year, how in the world do you catch the case of arsenic toxicity most of us will never see? This is a question I routinely ask myself. There are a few clues, but I think we have to be honest. The medical literature as well as the media confirms many patients are seen in the ED and discharged with presumed viral gastroenteritis or a basic stomach virus. Even after admission to the hospital, the diagnosis is often made on post-mortem exam. Do I think I could do better than your average ER doctor? Well, I'd like to answer yes. The honest truth is probably no. We certainly can't and shouldn't be sending arsenic levels on every person with diarrhea. It's difficult to have a high level of suspicion, as the history in these cases is lacking for obvious reasons. We got lucky in this case that our patient required admission due to dehydration and kidney failure. In real life, he probably would have been sent home. So what are the clues? Well, first is the repeated ED visit. Many victims are poisoned repeatedly over time before the fatal dose. Nobody gets a stomach virus 4 times in 2 months. That said, patients with undiagnosed inflammatory bowel disease or rare zebras like porphyria also present repeatedly for the same symptoms. Second, the stools themselves are a clue. The classic description is rice water stools, liquid and whitish in color like the water in which you've soaked rice. This is also a classic description for cholera infection, and back to this important fact in a few minutes. The last clue is on the EKG. This is question number 2 for the medical professionals. What EKG change supports arsenic toxicity? A, QTC prolongation, B, ST elevation, C, ST segment scooping, or D, J-point elevation? The answer is A. QTC prolongation is a side effect of arsenic toxicity. Again, this is nonspecific as it can result from electrolyte disturbances and medicines used to treat diarrhea like loperamide or Imodium. In truth, I'd be relieved if I made the diagnosis ante-mortem while the patient was still alive rather than post-mortem. Arsenic toxicity is tough, one of the reasons it remains popular with poisoners even with modern medicine at our fingertips. The fact that arsenic resembles cholera plays no small role in its popularity with murderers. In the past, cholera was extremely common, as was death from cholera infection. So arsenic poisoning resembled death from natural causes, thus its title, the King of Poisons. Arsenic toxicity has been well known for thousands of years. It's been around since at least 2000 BC as a byproduct of copper smelting. The word arsenic is derived from Persian and Syriac words incorporated into Greek as arsenikon, meaning potent. It was used as capital punishment in Korea and China. During the Joseon dynasty in Korea, nobles were executed with sayak, a mixture of poisons containing arsenic. It was thought that this was better than hanging or decapitation, though it's difficult to know if that was actually true. Apparently, the convicted person was put into a hut, forced to drink the liquid, then the hut was heated up to speed up the poisoning, with some victims sustaining burns as a result. Arsenic's popularity in murder really starts with the Borgias in medieval times. The family used it to murder political rivals and gain wealth and status. Lucretia Borgia is often portrayed as a murderess, though more recent evidence suggests it was her family, not her, doing the poisoning. Another case of poison being misattributed as a woman's weapon. It's said the Borgias used cantarella, a mixture of poisons speculated to include arsenic, copper, and phosphorus, though evidence of its composition and, in fact, its actual existence is lacking. Your phone rings, interrupting your thoughts. The hospitalist tells you the patient is delirious and just had a seizure. You recommend a spot arsenic test and a 24-hour urine arsenic collection. Because he's sick and getting worse, I'd treat empirically for arsenic toxicity. The spot urine will come back later today or tomorrow, and the 24-hour test in a few days. By the time we get the results, it might be too late. He's already headed down the seizure, coma, death pathway. You do wonder why he's getting sicker while in the hospital. Certainly, arsenic toxicity can start a cascade of symptoms, but on prior visits to the ER, he improved with supportive care. But he needs immediate treatment, so let's focus on that and ask questions later. Question number 3. What is the treatment for arsenic toxicity? A. Activated charcoal. B. Chelation. C. Whole bowel irrigation. Or D. Hemodialysis. Let me give you a hint. Arsenic is a heavy metal. The answer is B. Chelation. If you chose the other answers, I regret to inform you, your patient died. Charcoal doesn't bind to heavy metals, and whole bowel irrigation removes toxins still inside the gut, which is probably not the case here. Hemodialysis removes very little arsenic. Chelation is a critical intervention for our patient. In cases with high clinical suspicion, like here, treatment should be started prior to confirmatory test results. There are several chelation options. In the U.S., we have 2 choices, dimercaprol, an intramuscular preparation, or succimer, an oral one. Dimercaprol is indicated for sick patients, and succimer for mildly ill patients or those with subacute or chronic toxicity. In Europe, there's a third option, DMPS, which can be given by any route. Chelators work by binding to heavy metals and activating them so they can be excreted. It sounds great, and it does work, but the data for chelation for any heavy metal poisoning is never as clean as we toxicologists would like. There is some animal data suggesting chelation, while lowering blood arsenic levels, might increase the levels in the brain, which is obviously not ideal. But these are the options we have, and in this case, dimercaprol is the best choice for our patient. The medicine is given as an injection every 4 to 6 hours. Can you imagine getting a shot, and not a subcutaneous injection like insulin, but a real intramuscular injection like the flu shot every 4 to 6 hours for days and days? Dimercaprol is contraindicated with peanut allergies because the drug itself is dissolved in peanut oil. And it smells like sulfur, i.e. rotten eggs. Patients do not like it, to put it mildly, but it's better than death. The antidote itself has a really fascinating history. Its other name is BAL, or British anti-lewisite. Lewisite is an arsine gas, an arsenic-containing World War I era chemical weapon, which for some reason smells like geraniums. The British were concerned it might be used in World War II and developed BAL as an antidote. Fortunately, lewisite wasn't used in the war, but BAL was found to chelate other heavy metals and is now an important antidote. Back to our patient. His spot arsenic level comes back at 100,000 micrograms per liter, extremely high, confirming the poisoning and leaving no room for debate. Why do I say that? Because interpretation of arsenic results is complicated. I'm going to touch on this briefly as it's a point many, including physicians, don't understand. Doctors love to send heavy metal testing without understanding the nuances. Elevated arsenic levels are very, very common. Arsenic toxicity, you don't need me to tell you, is very, very rare. In fact, your arsenic level might be elevated. Mine too. Are we poisoned? No. Arsenic is ubiquitous in the environment and therefore in food. So question number 4, which of the following foods are high in arsenic? A, fish, B, rice, C, beer, D, barley, E, all of the above. The answer is A, B, and C. Fish, rice, and beer and wine all contain arsenic. Eating fish will raise your arsenic level above normal, but you can't eat enough to develop severe toxicity like our patient. Bottom line, random arsenic levels in regular patients aren't helpful. If for some reason you really need an accurate level, which is rarely necessary, the patient has to abstain from fish and rice for 2 weeks before testing. So if there's arsenic in fish, should we stop eating it? No, fish and fish oil are very good for our cardiovascular health. So our patient is now in the ICU, clearly arsenic poisoned and teetering on the edge of death, getting dimercaprol and supportive care. His wife remains at his bedside. While we wait to see if he improves with chelation, let's talk about the mechanism of arsenic toxicity. As with so many life-threatening toxins, it causes energy failure. In this case, it inhibits pyruvate dehydrogenase with a resulting decrease in ATP production. It also causes free radical formation leading to cell damage and interferes with gluconeogenesis or glucose production, causing low glucose intracellularly. Ancient physicians not only knew about arsenic's toxicity, but also its therapeutic potential. In ancient China, it was used to treat malaria. Hippocrates used it to treat skin lesions, ulcers, and abscesses. Interestingly, Paracelsus used it extensively, recording detailed instructions on its production. Remember his famous quote, "It's the dose that determines the poison." In the 1800s, arsenicals were not only ingested, but inhaled, given as enemas and as vaginal inserts and powders. Personally, I'm surprised anyone exposed to medicine, and I use the term loosely here, in the Victorian era survived. Think arsenic enemas are crazy? I did, but apparently we still have arsenic-derived suppositories to treat refractory proctitis. Research with arsenic for the treatment of syphilis led to the development of the first antibiotic, salvarsan, a play on the words life-saving arsenic. And arsenic trioxide is still used as a chemotherapeutic agent for refractory leukemia. A derivative, melarsoprol, is used to treat trypanosomiasis or African sleeping sickness. Really interestingly, this pharmaceutical preparation of the drug also contains BAL, which appears to reduce toxicity for the patients who take it without reducing the effectiveness of the drug. So who poisoned our patient, and why is he getting worse despite treatment? Apologies in advance because this episode ends with a cliffhanger. Want to find out? And want to know what the Victorian arsenic poison panic was and what finally slowed it down? You'll have to listen to the next episode, part 2, to find out, because I've already talked for too long today. Subscribe and you'll know when it's released. Last question, number 5 in today's podcast. What item did ancient Korean kings use to avoid poisoning? A, unicorn horns, B, silver chopsticks, C, bezoars, or D, ingesting small doses of poison to develop immunity? Follow our Twitter and Instagram feeds, both at PickPoison1, and you'll see the answer when I post it. This is a fictional case, as are all our cases, to protect the innocent, but it is based on real poisonings. Remember, never try anything on this podcast at home or anywhere else. Finally, thanks for your attention. I hope you enjoyed listening as much as I enjoyed making the podcast. It helps if you subscribe, leave reviews, and/or tell your friends. All the episodes are available on our website, pickpoison.com, or any other location where podcasts are available. Transcripts are available on the website as well. While I'm a real doctor, this podcast is fictional, meant for entertainment and educational purposes, not medical advice. If you have a medical problem, please see your primary care practitioner. Thank you. Until next time, take care and stay safe.
This podcast is a production of Unfiltered Studios. If you would like to know more about joining Unfiltered Studios, please visit our website at unfpod.com for more information.